We can start.
Yeah. So, good afternoon, everyone. Today, I'm introducing Dr. Akash Pandita sir from Medanta Hospital, Lucknow. So, sir will take the session today, lung ultrasound in neonates. So, doctor, over to you, please. Thank you.
Let me add one more thing. Dr. Akash Pandita, he is a director of neonatology, Medanta Hospital. He is having very good experience and very rich experience in neonatology segment. Earlier, he was with SGPGI Lucknow, and right now he is working as a director SG Medanta for neonate and pediatric. Over to you, Dr. Pandita.
Uh, Thank you for the kind introduction. So, in this class, we'll be talking about the lung ultrasound. Now, these days, ultrasound is called as the modern stethoscope because it is easily available, portable, and can be done multiple times bedside and gives much more information than the normal stethoscope used to go. So, today, the modality which we have chosen is ultrasound. So basically, point of care ultrasound is basically a bedside ultrasound, which we do to answer a specific focused questions. That is, we have some question in mind, we are suspecting a disease, or we are going to do a procedure. To answer that specific question or to do that specific diagnostic technique, we do an ultrasound at the bedside of the patient. That's called point of care. And with this tool in hand, it has led to better diagnosis, in fact, early diagnosis. And it is not only diagnostic, but many times it is also therapeutic and can help in doing the procedure with more precision and less complications. For example, pneumothorax, pleural effusion. So, with the ultrasound probe in hand, we can be more accurate. We can do the procedures easily and can do them timely and save the patients in time because time is precious, especially in ICU settings. And this ultrasound was initially developed for adult emergency medicine. For that, it has evolved, and almost every branch has now point of care ultrasound, in which includes neonatology also. And in fact, almost every organ is now scanned from head to toe with the help of this ultrasound. In neonatology, we usually do ultrasound for brain, lung, heart, abdomen, and for lines and tubes. So we'll be focusing mostly on the lung ultrasound. So there are various advantages attached to the ultrasound. First of all, it avoids the radiation, which was there with the conventional X-rays. It is readily available within the unit. The machine is always available within the unit. These days, we have smallest machines possible, which you can carry around in the unit, which are portable. Even pocket ultrasounds are now available. And the other major advantage with ultrasound is that it does not require any sedation and can be done easily, keeping in mind the baby's comfort. However, before doing a ultrasound, we have to be very careful. If we do not do it properly, then knowingly or unknowingly, we may land up with certain complications which are not good for the baby's health, especially in small preemies where there is a high risk of hypothermia. So whenever you are doing a lung ultrasound, especially if the baby is a premature baby and is an incubator, so make it sure if the baby is in the incubator, the protective mode is always on so that baby's temperature doesn't fall, baby doesn't become hypothermic. Similarly, in a warmer, if you're doing an ultrasound, ensure that it is in the air mode with at least 30 to 50% of the heater output so that baby is maintained euthermic. And during this procedure, one should always continue to monitor vitals, especially heart rate, saturation, and temperature. Remember that this procedure is for the baby. Baby is not for the procedure. The other thing which we can do wrongly during any procedure, whether it is ultrasound or for any other invasive procedure, is we can spread infections if our hands are not clean, the equipment is not clean. And always these days, even in India, now there are single use packets of gel available, which can be divided into two and can be distributed in two patients rather than using that conventional jelly bottle which we carry around for many days and which can be a source of infection. And last but not the least, always keep in mind what baby's feeding. Because of our procedure, the baby's feeding should not get delayed. So the best time to do an ultrasound is half an hour to 30 minutes after feeding, and we should always ensure that baby is comfortable. The other thing which is very important before doing ultrasound that you should change position if you are planning to do an lung ultrasound, because whenever there is fluid or air in the lung, if you change the position of the fluid and air at least takes 1 hour to settle down. So if you are doing a procedure, especially the lung ultrasound, do not change the procedure just before the lung ultrasound. Now coming to the probes, so one has to remember that for superficial structures, to get a better view of the superficial structures, we always use high frequency probes. Higher the frequency, less is the penetration, less is the visibility. So for superficial structures like lung and brain, we always use high frequency probes. For doing lung ultrasound, we prefer using a linear probe, that is 10 to 15 millihertz. And the other advantage with the hockey stick probe, which we commonly do use for lung ultrasound, is it has a small footprint. So for small preemie babies who usually have RDS, it gives a better overview. Now there are usually two modes for lung ultrasound. One is the B mode and the M mode. M mode is usually used for a fast motion to know the better details of a fast moving structure, and it is usually used to diagnose pneumothorax or pleural effusion. Now for doing lung ultrasound, which divide each lung into anterior part, lateral part, and the posterior part. The anterior part of the lung starts from the sternum to the anterior axillary line. The lateral lung starts from anterior axillary line to posterior axillary line, and then posterior lung starts from posterior axillary to the spine. So this is how we divide anterior, lateral, and posterior lung. Now each anterior part of the lung is divided into two parts, the upper and lower, as you can see in the picture. And this is the line down to the navel line. So where this is right upper, right lower, lateral, and the posterior part. And this is the hockey stick probe. As I said, because it has got a small footprint, it is very easy to do in small preterm babies. So for lung ultrasound, we commonly use hockey stick probe. And this is how the probe is kept. That is, we keep it perpendicular to the baby to get the better overview. If during lung ultrasound we find there is a consolidation, and we want to know how big is the consolidation, what is the lung involvement, then sometimes we can keep the probe even parallel to the ribs, because here it is crossing the ribs. In between intercostal space, we can get a better overview of the extent of the consolidation. Otherwise, majority of the times, the probe is kept perpendicular to the baby. Now you name the disease, lung ultrasound can be done for any of the diseases which we come across in RNICU, which includes respiratory distress syndrome, giving surfactant, pneumothorax, effusion, pneumonias, or even mucormycosis syndrome. So always, whenever you are doing a lung ultrasound, you should always keep in mind a particular systematic approach. Even for reading X-rays, we go by systematic approach so that we do not miss on any minor details. So usually in the lung, we use a ABCD approach. That is, we look for the A lines, B lines, look for any consolidation, look for the diaphragm. Diaphragm is important because by seeing the diaphragm, we know that I have scanned throughout the whole lung, and E is for any effusion. We'll come back to this slide once we have gone through the basic aspects of the lung ultrasound. So we look for lung sliding, A lines, B lines, consolidation, and effusion. So basically, whenever we do a lung ultrasound, we directly see only the ribs and the soft tissues. Whatever other things we see is all because of the artifacts, because the ultrasound rays cannot cross the ribs, cannot cross the air. So beyond ribs, we only see artifacts, and it is these artifacts which make the ultrasound interesting, because in rest of the ultrasound, we do not want any artifact to come. But here, everything is based on the artifacts. So in this picture, as shown on the left, you can see soft tissues. Then we have a pleural line, and then beyond pleural lines, we see various artifacts, and we will discuss them one by one. So this is the actual ultrasound picture which is shown on the right. So these wavy structures which are shown in the picture, they are the ribs, and below ribs, this bright linear structure is the pleural line. So it is also called as the bat sign. So whenever you are doing a lung ultrasound, your probe should be at the level of the pleural line. And if you are able to see this bat wing sign, that means you are at the right place. The probe is in the right position, you are good to go ahead. So as shown in the picture, the two ribs, they are shown as the wings of the bat, and below the ribs, the dark or the bright linear structure is the pleural line. So this pleural line with two ribs gives like a bat wing appearance. This is called as a bat sign. This is a normal lung ultrasound. So before reporting or before doing a lung ultrasound, we should be able to demonstrate this bat wing sign, so to know that we are at the right place. So coming to the A lines. A lines are normal find. A for air. So whenever we are seeing A lines, it is because of the air in the lungs. That shows the lungs are well aerated. What are these A lines? These are basically parallel artifacts, that parallel lines to the pleural lines. They are horizontal parallel lines below the pleura and are seen in the normal lungs, and they usually decay with the depth. As you can see in this picture, this is the bright linear structure is the pleural line, and then subsequently you can see multiple piles of horizontal lines. These are called as A lines, and as you go from top to bottom, they decay. These are called A lines. This is the real time ultrasound. So first of all, we should be able to see lung sliding. That is the visceral pleura and the parietal pleura. They will rub against each other. That's called as lung sliding. So whenever you see lung sliding, it immediately rules out any pneumothorax. So it rules out pneumothorax. It shows that the pleura is healthy. The visceral and the parietal pleura are rubbing against each other. That's called as sign. And below this pleural lines, you are seeing multiple parallel lines to this pleural line. They are called as A lines. A lines tell me that my lung is well aerated and it's a normal run. Then there are also horizontal lines which are hyperechoic waves projecting vertically from the pleural line to the bottom of the screens. They are usually not seen in the normal lung, or they may be one or two immediately after the birth. So few B lines immediately after the birth are normal. But if you are seeing three or more B lines in one plane, they are abnormal. They are called as interstitial syndromes. They tell us that lung is not aerated, lung is collapsed, there may be pneumonia, or it may be a feature of RDS. So as shown in this picture, these are perpendicular lines originating from the pleural lines, and they do not decay. They remain bright. It's like a torch shown in the dark room. These are called as B lines. Remember, B lines immediately after birth can be normal, but three or more than three B lines in a single field are abnormal, and they tell me that either lung is collapsed or there is a consolidation. For example, as seen in RDS or pneumonia. So this is how the B lines look in actual lung ultrasound. See this picture on the right side. You see a bright horizontal structure, this pleural line, and perpendicular lines which are originating from this pleural line up deep to the lung. They are called as B lines. Similarly, we can see this picture here. So as shown in this picture to the left, three or more than three B lines in a single ultrasound plane, they are abnormal. Now we'll see how the conditions look in a lung ultrasound. First, we see consolidation. So in consolidation, the pleural line will become thickening. You can focus on the A picture. You will see that the pleural line is more bright and is thicker. And also there is loss of A lines. That is, you cannot see the A lines. The lung gives like a whiteout picture as we see in X-rays. So there is a confluence of B lines. That is why we cannot make out there is any A line. So absence of A lines tell me that there is no aeration. Lung is collapsed. So this is a picture of RDS, that is whiteout lung. So also there is a scoring, lung ultrasound scoring for giving surfactant, and there are multiple scoring systems. And the commonest one which we use is shown in this slide. That is, lung is divided into three regions: the anterior and the lateral. As I said, the anterior lung is further divided into upper anterior, right anterior, lower right anterior, and similarly left lung is divided into three parts, that is upper and lower anterior and the lateral. So three on each side. Total we have six regions. Here we do not take into account the posterior lung. You may or may not scan posterior lung, but majority of the scoring they only see the anterior as well as the lateral part of the lung. So in total we have six regions for scoring. So we have, for each lung region, we have a score of 0 to 3. So that is total score of 18. 6 regions, 0 to 3 scores. So any score of 8 or more tells me that any preterm baby who has a lung ultrasound score of 8 or more tells me that that baby needs surfactant. So how to score? A score of 0 is given if there are less than 3 B lines. 1 is given if there are more than 3 B lines. 2, when there are multiple B lines, just as we saw in the picture, that you cannot count. They are totally A lines are disappeared and totally white out lung. And then score 3 we usually give if apart from the white out lung, we have a consolidation of more than 0.5 centimeter. So the multiple studies, including meta-analysis, have shown that lung ultrasound is better than X-ray in predicting the need for surfactant. It has decreased our time to give surfactant because we know that the best utility of surfactant is to be given within first 2 hours of life, because that is when the lung is still expanded, it is not completely collapsed. And it has got a very high sensitivity and specificity of almost 90%. The diagnostic odds ratio is almost 3.8 with a negative predictive value of almost 90% and positive predictive value of 80%. So then how to differentiate between RDS and TTN? So RDS is a homogeneous disease, whereas transient tachypnea newborn is a heterogeneous disease. So focus on the picture B. You will see that there is a normal lung on the left side, that there is a pleural line and the multiple horizontal lines. And on the right side of the picture B, you will see there are multiple B lines. This is called as double lung point. That is, in the same lung, you will see well aerated lung as well as the consolidated lung. This is called as double lung point, and this is pathognomic of transient tachypnea of newborn. And when for such babies, as you do multiple ultrasound, you will see that more and more lung becomes normal within a span of 24 to